Hello, dear colleagues, ladies and gentlemen. I'm glad to welcome you at the session devoted to maritime medicine. I was asked about 10 minutes ago how maritime medicine appeared in the agenda of the conference. We met with Mr. Lgunov time ago, and we realized that marine medicine and remote medicine shall go hand in hand with each other, and we meet almost at every conference. Our first speaker is Yuri Zakharevsky, professor, head of training in the specialty general medicine, Murmansk Arctic State University, corresponding member of the Russian Academy of Natural Sciences, neurosurgeon of the highest category, colonel. He's a well-known military doctor. Please, you have the floor, Yuri. Hello, we're happy to see you. Do you hear us well? Now you can take the floor. There are some technical problems, and they need to put on the slides on the screen. You can begin, and then we will try to fix the problem with the video. I will begin the report then, and we will see how it goes. Dear colleagues, the volume and nature of medical care in the Russian Navy in the sea, as in any countries of the world, is always determined by specific historical conditions, development of medical science, and medical equipment and technologies, achievements of naval surface and subsurface ships, creation of direct conditions for medical healthcare in the sea. As the technologies medical technologies are improving, and the medical equipment and tools are developed, we have more opportunities for providing decent and efficient medical care, especially at naval surface ships and submarines. From the point of view of the history, the first submarines in 1909, they were rendering medical assistance to each other, the seafarers. But then in the Soviet Union, there was a paramedic position introduced with the necessary medical toolkit. Then German and Russian ships during the First World War had experienced the need to engage medical personnel, be present at submarines to provide the necessary medical care. Then in the 20s and 40s, due to the great number of submarines, there was an urgent need to have a paramedic on board. And this happened until the end of the Second World War. For the first time, the issue of surgical care in sea appeared for the first time in 1942 with an increase of the duration of the submarine routes and voyage in the sea. In many cases, they diagnosed the acute appendicitis in the Atlantic in the sea. So there were many cases with appendicitis. And until 1946, the surgeries were not performed on submarines. Due to the development of the naval navy, on the Russian Navy, they built 337 submarines, nuclear submarines, and other types of submarines. The scope of medical care increased a lot. The first surgery was done in Russia was by a doctor from Petropavlovsk hospital underwater. In the future, after 1957, such operations were performed in all submarines, and their number was increasing. In 1957, in the Soviet Union, they introduced a position of a surgeon in all submarines in the oceans of the Soviet Union. And starting 1956 up to 1900s, there was a golden age of the Soviet Navy surgery. There was a department and an institute that trained surgeons for naval industry, that were able to make these surgical operations both on ships and in submarines. And since then, hundreds of surgical operations were performed. The construction of nuclear submarines and their submerging under ice also created the need for surgical operations. And 165 operations were performed, including the most serious ones. Despite the lack, since Russia and the Soviet Union didn't have hospitals along the seashore of the world ocean, the Soviet Union decided to build the supply base that would provide the necessary facilities and equipment and personnel to these seafarers. So about 30 of such units were built at that time. Besides all the necessary food that was available for seafarers, they provided the necessary medical care. There was a surgeon, a pediatrician, a therapist, and a resuscitator. So all the operations were also conducted, not in the submarine, but, for example, in these specially designed medical centers. Down those floating bases, as they call them, were improved, and the amount of necessary medical equipment was also enhanced. And here on this slide you see some examples of the big ships that were designed especially to provide the medical assistance to people serving on board. There was an active construction of specialized military ships. These are the floating hospitals. One of them you see here on this slide. One of them is actively used in the United States. They are used in military actions in Iraq, for example. Scientific journals publish a lot of articles about the advantages of such ships. There were 4 hospital ships for medical support of marine workers. And you see also them on this slide. They are called Yenisei, Svir, Irtysh, Ob. They contain a resuscitation room, resort room, the room of neurologists and many other specialists. Up to 450 beds for the patients. Such ships are also widely used in emergency situations, in rescue events. Sometimes such ships are also used to provide humanitarian aid to the countries suffering from some disasters, for example. You see what is the quality of these beds and the wards inside those ships. They seem to be rather good. This made it possible to provide medical assistance to seafarers on board and to evacuate the injured people from the ship. Like on the 25th of March from Virginia ship, they were able to evacuate a seafarer, and in April from Georgia ship, they also transported an injured person to the hospital, which is very important in our days. Active surgical activity in the sea with the surgical teams. In submarines, there are 2 surgeons normally, and they have all the necessary knowledge and skills to provide medical assistance and do the operation under sea. Besides, the problem of traumas is quite relevant. The problem with emergencies, accidents. Then the John McCain ship, in case of emergency, on the 25th of August 2017, 10 people died and 5 were injured. There was a need for evacuation, and on the 11th of June, the Fitzgerald ship also collided with another ship, and several people were injured. So the necessary medical assistance was provided on time. Important events on the prevention include medical checkups, pre-route examination. According to the order of the Ministry of Defense of the Russian Federation, 100% medical expertise is required for all the employees of the ship or a submarine in order to detect any hidden pathologies and to prevent any diseases or illnesses in the sea, so that such unexpected situations do not occur. There are protocols and certificates based on those examinations. For example, to prepare the crews of large ships, can you go to the previous slide? There is a need for deep examination. For example, it may be 2,000 seafarers or 1,000 seafarers. So this requires a detailed examination. We can say that this approach of pre-route examination was justified, and we were able to prevent and early detect the diseases the seafarers might have before going on a long route. Due to modern requirements to medical care in sea conditions, the Russian Federation tried to reinforce the qualification and number of doctors serving on ships. For example, starting in 2015 to 2018 or 2020, in this North Fleet, there were 26 reinforcement groups, as we call them. And you see in 2016 it was 21 group, 2017 32, 2018 28 groups, 38 of which were workers. In order to provide medical assistance, they attracted the specialists from Maritime Academy, which made the quality of training of marine staff stronger and improved the quality a lot. Now the naval medicine includes different specialties like surgeons, neurosurgeons, resuscitologists, dentists, and so on. This slide shows you the medical brigades recommended for large surface ships when performing their voyage in Syria to fight with terrorism. An important achievement of the Russian naval medicine was the highest level of specialized medical care, namely the introduction of laparoscopy, presence of mobile laparoscopic equipment, SKT-1 produced in Russia, manufactured in Russia, and some Russian ships already have this SKT-1 laparoscopy complex installed on ships, which makes it possible to do the surgeries at a different level. So this is an example of a surgery in sea under urgent conditions. Here we see the statistics of the rate of traumatism. The general illness level, incidence level was also reduced. So the number of people with good health is increasing year by year. Our teams provide medical assistance when getting from south to north seas, and due to these climatic changes, different problems with health arise, like pneumonia, lungs of different severity. A dentist help is provided in specially equipped rooms that are available on large ships. There are some mobile equipment, dental equipment also that can be placed on smaller ships. So these are the examples of tools for functional diagnostics, ECG, fluorography, and many other treatment methods. So every single ship is equipped with this devices that are able to perform various types of researches and examine the health of seafarers. One of the tasks for the Russian Navy is the introduction of the first and second rank ships, the telemedicine complexes that are well recommended and that are highly efficient. That are in using the telemedicine equipment. They transmit the necessary data, decode this data, provide the report to the in-ground or inland facilities. Up to 2024-25, we plan to equip all those large ships with telemetry equipment in Russia. An important task of the Russian Navy is to fight with infections and prevent those infections, especially in hot areas. This concerns the yellow fever when they travel around the African continent. So vaccination against this yellow fever is obligatory before seafarers get on ship. In case of other injuries, there are some training sessions arranged how to provide the first aid treatment, how to save the injured from the sea surface, and other medical care. In the Karachi port in Pakistan, we conducted a joint training with our colleagues how to render medical assistance in case of gun injury. An important component is to prepare the ships and the medical rooms for long voyages. Then for this purpose, the Russian Navy has a special algorithm and procedure for training, equipment supply, oxygen supply, other medical tools. All services of the ship are checked, including the medical service, before the ship begins its voyage. This inspection is on the readiness of the ship, on the necessary equipment, the necessary medical drugs, equipment, devices, oxygen. They check also the knowledge of medical workers in terms of different pathologies that may occur in the sea. Yuri, you have to sum up because we are running out of time. In order to save life, this is done in order to save life of the seafarers in any place of the world. Thank you for your wonderful report. If there are some questions, can you introduce yourself first? Hello, Yuri. My name is Denis Starostin, resuscitologist. Thank you for your report. It's a pleasure to know that the Russian naval medicine is doing well. Can you tell us how do you account and store drug precursors in sea ships. Thank you for your report, but regarding the drug preparation, this problem was stored and this problem of drug preparation is solved according to the regulations of the Russian government, and they are kept in a special box for and are only used for special purposes. So we handle them as prescribed by the law, in other words, or by the order. They are only used in emergency or in military events. So this problem is no longer a concern of us. Thank you. Thank you for your interesting question. Now we have another question. Can we use the competences of the Ministry of Defense and use this order for civilian ships? Because this will make our life easier, but this is another discussion. So we shall turn to the next speaker.
It's a dear colleague of mine, Luisa Polina Canals from Spain. Luisa here is a specialist in occupational health and hygiene, and she was the founder of the postgraduate courses for maritime medicine in the University of Tarragona. They started first in Tarragona, and then they were transferred to the Cadiz University in Spain. It's about training fishermen and seafarers for the medicine on board. Just a remark that in Spain, fishermen and seafarers are one single group. They are not divided into two groups, and they receive common training. So, Luisa, you get the floor. Please go ahead.
This good morning in Spain, but finally we managed to connect with you, and it is a pleasure for me to be invited to these interesting meetings. I was already in the one in July, and so it is a pleasure to be with you again. So the subject I will talk about is a little bit different. I will share my screen. Okay, I hope you can see it. The title this time is talking about tools and training related to the fishermen and seafarers for telemedicine on board. What does it? This means that mainly the knowledge that they have been learning in the courses, the first aids and medical care courses, will be applied for the radiomedical advice consultations. So they will be the eyes, and they will be touching, exploring the patient. They will be the ones that are commenting what is happening on board with the injured person or the seafarer that has a disease. So this is very important to have this health responsible on board. And I want to explain to you how we are managing in Spain in my maritime health program. That is a program that belongs to the government, to the ministry. And it is for all Spain. And as far as I was explaining to you last time, it's complete. The maritime health doctors in Spain are doing training, seafarers and fishermen, and doing the medical examinations, are doing radiomedical advice consultations, are in hospital ships, are also participating in the repatriation of the seafarers and fishermen that are working on board, especially in Africa. So this is a complete program for us. And we also are doing the inspections on board. The Maritime Labor Convention 2006, for example, and others. So, well, here, this is what we are pretending with these courses, that is the prevention. So we give them some tools like the first aid kit in the small ships and a big medical chest in the big ones. We are following the STCW convention, IMO, and we have ratified the European directives related to the training also, and related to the medical chest, and related to a lot of rules and regulations that are transferred in the Spanish rules and regulations program. We have mainly these three types of courses: a basic for all the seafarers, initial for the responsible of the first aid C, because in Europe we have three types of medical chest. The smaller one is the C, and the biggest one, that are three, it is complete, we will see some pictures, is A. A and B are very big, and C is a small one, a first aid kit. So these three courses, the basic, the initial, and the advanced, are addressed to different positions on board different types of ships. And also we have every 5 years a refresher course. So the two that are related to the responsible person on board of the health are the initial and the advanced. The basic is for all seafarers and fishermen, it is compulsory. So this would be the basic, compulsory for all seafarers. Why? Because in case of accident, everybody has to be prepared to assist this person, to reduce risk and to take an immediate action to avoid fatal sequelae. These are very different types of accidents on board, but many of them implies also an injured person. We are doing a lot of campaigns, health promotion for preventing the accidents, and teaching what are the risks in each part of the ship. We have also some manuals or books that they have to follow, and they have all this training also online. For example, the specific initial medical care training course, and the objective is to give them competences in first aid, elementary nursing techniques, and radiomedical consultation procedure training. This is the main important part. The telemedicine that they are using on board when they are injured or when they have a disease. So it is addressed to the creation of this responsible person of the health on board. It can be captain, a skipper, officers. So they, for those that have the first aid kit C, according to the European Union directive, they have to have this course and a refresher every 5 years. For example, this is a fishing ship, maybe navigating less than 10 miles far from the coast, but they have these small first aid kits, they have a medical guide on board, and they are trained to solve any problem, and they also can have these radiomedical advice consultations. For these ones, we are, for those that are choose to be trained presentially, they have 24 hours teaching, 11 theoretical that can be online or can be presential, and 11 practical, never online, but practical. So they are able to contact with the radiomedical advice center, and also they have some tools to facilitate the consultation. For example, this is a drawing, a picture showing for example, if they want to say the painful area, they can show with these letters and numbers to the doctor that is in the radiomedical advice center. Okay, so they get their diploma with the contents of the course. In the case that 5 years after this course, they need to be a refresher. The refresher is always practical. It has to be presential. And we have a we short the content of the course, but all is in practice. No online for this part, if it is a refresher. So they have to learn how to, for example, in the practical, how to take the blood pressure, or how to transport an injured person, or to make bandages. This is the advanced one. For the advanced course, then we have higher objectives, and it is addressed to captains, skippers, and officers that have to be in charge, the health responsible person for the medical chest A and B. So these persons are also controlling hygienic conditions on board, and they are the responsible of the risk prevention programs. So if you look at the medical chest, this is bigger. This is the B. For ships that are going more than 60 miles far away from our coast. They have even oxygen and other devices. This is the distribution, the timetable, the subjects, and these ones receive 40 hours teaching. The theoretical content can be done presential or online, and it is about 18 hours. And the practical content, always presential, has to be at least 21 hours. This is the tools we are using for training to learn the anatomic, the body, to check the patient for the exploration on board, how to transport, even how to use for example, special nursing techniques like endovenous punction for some special treatments. So these ones are well trained. And especially, we insist on the resuscitation techniques. How do we evaluate these courses? Well, online, if they choose the online for the theoretical part, in this case, they pass some test, and when they are prepared, they have till 4 months to contact to a center in the coast where we have our maritime health doctors and do the practical part. I say till 4 months because sometimes they are starting the online part and then they are navigating and they then do not have the possibility to go on land for the presential classes. So we give this time, but the normal thing is that they do the online part, the theoretical part, and then immediately they can go, if they are on Earth, to this Maritime Health Center to do the practical part. And if they are doing all presential, they can only miss 10% of the classes. What we are doing for the evaluation, normally we are testing the knowledge, the aptitude, and the skills. So we have a multiple choice examination with normally 4 possible answers, 1 right, and they have to have 75% good to pass this exam. But we also evaluate the practical part. And for the online, there are also regulations in Spain how to do this. Not only the government can do these courses, but also some private schools that have to be homologated, and they are audited for the maritime health doctors. The diplomas are always given by our government. So we prepared these seafarers and fishermen for telemedicine, for the radiomedical advice consultation, and to be there as the responsible person on board, because they have no doctor on board, but they have these telemedical possibilities. So they have to transmit the information, they have to explore the patient, and they have to take the action recommended by the doctor. These are some statistics of pupils. If you see, for example, this year courses, now a higher number of seafarers and fishermen choose the online part for the theoretical part. Many of them are coming from the schools, of the nautical schools, and they are now used to these techniques too.
Luisa, you have 2 minutes, please.
Oh,
Yes, you have 2 minutes left.
and prevention. This is a link in our program, and these are spasiba, thanks. And these are the information that doctors have also to be trained in maritime medicine. That's all. Thank you.
Thank you so much, Luisa. Muchas gracias. Если у нас...
Thank you, Luisa. Do we have questions from the audience now? We do not have any questions in the chat, and we are now moving forward to our next speaker, who is...
This is a young doctor from Thailand, Pangrup Charyen. The fleet in Thailand is also quite young. It was established in 1946. Marine medicine in Thailand is quite young. So they decided not to invent a wheel. They invited the best specialists from the whole world and together created one of the most ideal systems that exist at present, with 3-year training of marine doctors at the universities of Thailand. Can you hear us?
Hello. Kapun Kaka.
สวัสดีค่ะ
Sawadika.
I could not hear you, Ilona.
And now?
Okay, I'm listening to you.
Okay, please, the floor is yours. You can start your presentation.
Okay. ยิงถูกแล้วก็ Could you see my slide?
Yes?
Okay, thank you very much. Thank you for your invitation for this conference, and good afternoon, everyone. It's a pleasure to have you with us today. Let me briefly introduce myself. I'm Lieutenant Commander Pangram Yongchalerm. I'm a specialist in board of preventive medicine and in sub-board of maritime medicine, and currently working in naval medical department in Thailand. The topic I would like to talk about is the vaccination in Thailand seafarers. I've divided my presentation into 4 parts, And I will begin with introduction. Then I will move on to types of vaccination. The next is vaccine preventable disease. And after that, the conclusion. There will be time for question after my presentation. First of all is an introduction part. Seafarers can be considered as a unique population with its own needs and constraints and requirements for international travel. And of course, to protect the health of seafarers, passengers, and the general public, and to minimize disruption of global supply chains, vaccination of seafarers is considered highly preferable. Because of seafarers have to worldwide travel, embark at any port in any country, so they have more risk of infectious disease significantly in different parts of the world. Therefore, pre and post traveling assessment, including after starting on board, assessments are necessary as well. We have to get the idea that what the pre-travel counseling concept is. It consists of background of travelers, risk of traveling, risk assessment, and risk management. The background of traveler you have to consider is what drugs seafarers have used until now, or what the disease at sea that seafarers could have, or what the vaccination seafarers have received before. And for the risk of traveling, you have to know about where the seafarer traveling to, or how long of period they have to stay that place, and what season or the target destination seafarer traveling to has the endemic disease or not. And the last one is risk management. If you know what risk is, you could manage the risk and control it before going on board, such as giving them the vaccination to seafarer, or maybe have somebody check the lab if they have any health themselves problem. The next part I would like to talk briefly is types of vaccination. In general, there are two types of vaccination. One is live attenuated vaccine or LAV, and two is inactivated or Q vaccine. LAV has a strength part that it induces strong lifelong immunity more than Q vaccine, while Q vaccine has more stable and safer than the first group. LAV is, for example, typhoid vaccine, yellow vaccine, and varicella or zoster vaccine. And the Q vaccine is, for example, influenza, hepatitis A vaccine, or rabies. Let's now take a look at vaccine preventable disease. And since we have not much time, so I will emphasize only VPD. Vaccine preventable disease could divide into three groups. One is required vaccines that the seafarer or travelers must be vaccinated. Otherwise, they could be rejected to travel by authority of that country. Two is routine vaccines that they are expand program of immunization or EPI of each countries. All population in the country must be vaccinated. And the last one is recommended vaccine that the medical staff would consider of all pre-traveling concepts as I have talked before. About yellow vaccine is kinds of serious viral hemorrhagic fever and but borne transmission. Its vector-borne is spread by Aedes, and symptom is some kind like influenza-like illness with fever, headache, or maybe some have nausea and vomiting. Of course, nowadays, no specific curative treatment for yellow fever, but anyway, it can prevention by vaccination, especially in seafarers who have to travel in the endemic area. In this yellow fever map by CDC shows the epidemiology of yellow fever. And as you can see, the vaccination has been recommended in the country in Africa and South America that highlight with yellow color. Endemic in 42 countries in Africa is about 29 countries, and South America divided in 13 countries. And what about risk of yellow fever? The data here show that WHO estimates some 200,000 cases occur each year, which almost all of these are in sub-Saharan Africa. And the risk for fever will focus that fever are at risk in all areas where yellow fever is endemic, and the risk is greatest to visitors who enter the forest and jungle areas. WHO position vaccination strategy to endemic countries and travelers. And to sum up in this table, yellow fever vaccine should be offered to all unvaccinated seafarers who are traveling to and from this area unless the vaccination is contraindicated. In this slide content, I would like to show that the yellow vaccine is safe, affordable, and highly effective vaccine. Besides, its effectiveness is quite strong and lasts long immunity. And of course, it's widely used to protect seafarers or travelers of endemic regions of tropical South America and Africa. The right yellow picture is the figure of yellow vaccine logbook. It is a proof of yellow fever vaccine vaccination and being signed by authorized physician. Exactly that failure to secure validation can cause seafarer to be quarantined, denied entry, or possibly revaccinated at the point of entry to any country. For the hepatitis A, typhoid, cholera, and polio, I would like to focus about the risk for seafarers. In hepatitis A, the risk of infection is involved with non-immune seafarers that visiting to developed country, especially who exposed to the poor hygiene of food or water condition and sanitation. So that the indication of hepatitis A vaccine, some textbook of journals suggest that the catering crew staff must be free of enteric disease. And for typhoid, in general, typhoid has low risk to seafarers, except in parts of North and West Africa and South Asia. Both continents is still in high risk, and the risk of infections is involved with low standard of hygiene and sanitation as well. The vaccination is recommended to all travelers or seafarers who go into this area. Besides, cholera and polio is recommended for seafarers that should be vaccinated when visiting area with ongoing or expected that disease in epidemic area. And the last vaccine I would like to focus is COVID-19 vaccine. Many COVID-19 vaccines authorized for use in different countries that they are reported to be more than 50% efficient in preventive disease in those vaccinated. But in some cases, efficacy data is not yet public or peer reviewed. After the injection vaccine is given, the protection starts to develop approximately 12 days. And it's stated it is currently unclear that the authority in different countries will accept all vaccine available today or in the near future to permit entry within their borders. And always recommend information about the vaccine obtained and hard or electronic copies to certify proof of vaccination. Somehow, they are currently recommendations that if the seafarer have to shot the vaccination, they suggest that second dose of vaccine should be the same as the first dose. This data, I would like to show you some the data I have received from Thai Ship Owner Association or TSA. They state that about the problem they face now is one is current situation or problems. They state that stakeholders or government do not have clear or exact protocols or guidelines for all Thai seafarers. And they have registered by application, but most of them could not access to any vaccine, or maybe they could not receive second dose at the destination country, although they have the single dose in Thailand. And or maybe while on board, seafarer has been notified to get the vaccine at the vaccine center in Thailand, although they still may be on board at the sea. And what should they action now? They do now by try to contact or coordinate it with other stakeholders of government to have the clear resolution. But some of them have the depart although did not receive the single dose vaccine. And of course, they try to contact the destination authority to receive the vaccine. And the last one is how they resolve suggestion from Thai Ship Owner Association. The stakeholder or Thai government should have the clear protocol for all seafarer vaccination of COVID-19. And they think that Johnson & Johnson or J&J vaccine is preferable because it's used only single dose. And somehow it will not be approved by Thai FDA. Or maybe they suggest that if the seafarer is still on quarantine center, for example, hospital, the seafarer should get the vaccine at this time for have not lose weight waste time. But now Thailand have mainly vaccine about CoronaVax, AstraZeneca, Pfizer, or maybe have some Moderna. We think that it approximately come into Thailand before this December. But now in Thailand, combination vaccination that recommend is Sinovac plus AstraZeneca or AstraZeneca plus Pfizer. As a final point of conclusion, I would like to have a little take-home message that prevention and precaution before departure is important, and understand and realize the target destination of local disease or endemic areas is important as well. And I would like to emphasize again, to protect the health of seafarer passengers and the general public and to minimize disruption to trade of global supply chains. So the vaccination of seafarer is considered highly preferable. Okay, thank you for your attention. Or if you would like to ask or discuss with me about the presentation, you could contact me by this email I showed to you. And if you would like to follow and subscribe about academic activity of Maritime Medicine Resident Training Institute in Thailand, you could follow by this page Facebook in this slide I showed to you. Thank you very much again, Ilona. I return floor to you.
Thank you, Pangrum. Большое спасибо. Если у нас...
Thank you very much. Do we have questions? We have one question. Dr. Pangrum, thank you very much for your interesting report. Can you tell us, you mentioned the training or preparation of seafarers in Thailand and their vaccination. As you know, in 2004, there was a horrible event in Thailand. It was a catastrophe, a tsunami. Can you tell me when you developed these special training programs or the programs for the preparation of seafarers, did you took into account some mechanisms or approaches or scenarios to train them or to prepare them for such extreme situations? Thank you. Can you tell me, are there any special programs to train seafarers in case of catastrophes or emergency situations? Are there any training programs for seafarers in case of emergency? Yes.
About in your question, I understand, but I think that the data you asking me is have to I would have to check with the port authority in Thailand, because in the event of tsunami last 10 or more years, I'm not sure about the data, but I will have to check the data for you as soon as possible and answer to you immediately as I can. Thank you.
Thank you, dear Pangrum. Я, наверное, хотела бы добавить, что
I wanted to add, Pangrum was talking about vaccination. Unfortunately, these days, right now in our countries, they forget about other types of vaccination, because the only vaccination important right now is the COVID-19 vaccination. So only those seafarers that work on cruise ships and on offshore platforms are vaccinated. For other workers, no one long. And nothing shall be changed in certificates. And you cannot imagine what people do. They ask for new certificates. They want to change some wording. Some doctors do another vaccination, and they tell that this is for the rest of the life. There are 4 papers. There are 4 sheets of this document, and everything is written, even in Russian. So I strongly recommend that my colleagues read through this document. To crewings, to ship owners, so that not to confuse our seafarers and avoid additional costs, because sometimes they have to fly to another city to be vaccinated, which is irrelevant. Our next speaker
наверное,
is a person who probably knows a lot about the problems that our seafarers come across, especially in today's situation with coronavirus, when it's impossible to replace a person unrelated to coronavirus. It's Igor Kovalchuk, the vice chairman of Russian Trade Union of Seafarers, and he's going to be covering the topic of the crucial issues of medical support for seafarers. You get the floor, Igor. Please go ahead. Good afternoon, Ilona. Even though the name of Ilona stands under your face, I recognize you, Ilona, and I'm joyful that many colleagues are able to see me right now. Unfortunately, I couldn't take part offline. I wanted to be there with you in the audience, but I will try to share my screen now and work in this online mode. Can you hear me well? Yes, we can hear and see it well. So the question that I'm going to cover is, on one hand, is straightforward and simple. On the other hand, it's a complicated issue. In July 2013, a convention on maritime labor entered into force. I was in the audience when this convention was ratified. It was a voting that took part. So in 2006 it was ratified, and we were hoping that the Russian Federation will be implementing the requirements of this convention in a good speed. This Maritime Labor Convention presupposes certain requirements for different maritime aspects, including medical. The Russian Federation enforced the compliance with this convention, stipulating by regulation versus different ministries. So the Ministry of Health received the regulations 1.2, 4.1 and 4.3, which are the points of the conventions that have to be enforced by the Ministry of Health. So it should have entered in force in 2013, but unfortunately it's been only after 4 years when the first list of diseases was the only legal act that was adopted in Russia to comply with the requirements of Maritime Labor Convention. Nevertheless, even this document is controversial. It gave a lot of room for discussion and the rest of the aspects that the convention stipulates was also discussed. The Ministry of Transport has a special committee, interdepartmental committee, that is responsible for the compliance with the convention. This committee includes different departments and ministries, including the Ministry of Health of the Russian Federation. These questions, controversial issues, were also reviewed during different meetings, such as the Committee of the Labor and Health Regulations. In the Russian Parliament, there was a special meeting dedicated to the medical care for the crews of ships in the Russian Federation. But nevertheless, this list is the only document that was adopted. Due to this fact, there are 3 issues: determining the order of medical survey or medical examination for seafarers and requirements for medical certificates of their health condition. Also, a list of medical organizations needs to be prepared organization and doctors to authorize medical examinations for the seafarers. And the third point of interest is the need to determine a composition or what is contained in the ship's first aid kit or medical chest. About the present state of the medical checkups, I need to say that the Ministry of Health tried to tackle this issue several times, and some regulatory acts were created, but in the last version of this regulatory act there was even no indication of any international requirements, even though we know that the Maritime Labor Convention should be mentioned and the STCW Convention, the International Convention on Standards of Trade and Certification. It is not there. They should be there, it's not there. And the Ministry of Health of Russia finally has developed the project of the law that takes into account the international regulations. This draft of a law at this point has went through the committee's review from the Water Transport Ministry. And the Ministry of Health, according to the latest data, are ready to present it in its in the way it is right now, so that the trade unions of seafarers and ship owners could assess it and evaluate this document. However, even though the list does include the color visions and indications and examinations, the latest requirement that was ratified it says that the medical examination should be in compliance with the international recommendations published by the International Lighting Commission, CIE. There is a standard that obliges it, or a similar standard. At this point, the methodology is not identified in this document. We hope that it is identified and included in this document, because at this point the color vision tests are being carried out, we can say informally, since there is no single document and single recommendation. Different medical commissions use different requirements. So we receive complaints from the seafarers. There should be different requirements to different crew members. The requirements should be different, for example, for person who stand outside and watch the outside sea, and to the persons who are sit inside, for example, of the control room, and they have to have a good color coordination of different lamps and indicators, and organizations or doctors who have a right to do medical checkups, medical examinations for the seafarers. This list needs to be also identified. Just until recently, the situation with the Ministry of Health was as follows. Any organization that has a license for medical services can provide medical checkups. However, it's quite obvious that the specialists who work for the medical examination of the seafarers need to have special knowledge about the peculiarities of work, about the specifics of maritime medicine. What are the typical diseases that seafarers suffer from? So it's obvious that this doctor or this organization has to be specifically trained. Oftentimes, we see that incompetent specialists work on the medical examinations. We get complaints from the ship owners that the quality of the medical checkups is something that leaves much to be desired, and the quality needs to be higher. This being said, we hope that the work of forming a list of medical organizations and doctors who have a right to perform medical checkups will be somehow clarified and determined. Also, we do have different interaction with the organizations that provide the medical services to the seafarers, and we keep contact. We keep a close contact with centers of we call FMBA, and the centers that do know the specifics of the maritime medicines. So we hope that they might be one of the operators for the medical examinations. Also, a form of special medical checkup needs to be both in Russian and in English. So the template should be created both for 2 languages, and as the latest info is that they heard us and it will be in both 2 languages. Another important aspect is first aid kit or first aid medical chest. The presence of strong painkillers in the first ship aid kit should be also linked to the training of seafarers. The system that is present now unfortunately does not allow to have strong painkillers on board, and this leads to many controversial situations. When a Russian ship comes to a Russian port, they have to have, or they cannot have strong painkillers, but when they come to a foreign port in a different country, they have to have strong painkillers. So you see that's a quite controversial situation, and that's something that a ship owner has also to take care of, to buy it, even if they to buy the strong painkillers when they are not being used even. It is also included in the Convention on the Drug the transportation of narcotic drugs is not considered to be a transit internationally if it's a part of a first aid kit. So some strong painkillers that are aboard are not considered to be luggage or import. They are considered to be a part of a special medical kit. So it's quite obvious that we have to work through the questions that I've just mentioned on the legal level. Moreover, the MLC contains also a requirement to have someone aboard who is able to provide medical health care, including also intravenous injections. So there has to be a person who is trained to do such procedures, to perform such procedures, and also the regulations should allow have strong painkillers, and these two factors need to be linked together so that we do have the one requirement for both, and it will facilitate the transportation in between foreign and Russian ports. Despite it's been over 8 years after MLC entered into force, the implementation of its medical requirements, it's still being hampered. That's the evergreen board that got stuck in the Suez Canal. So thank you for your attention. The seafarers are waiting. Thank you so much, Mr. Kovalchuk. I think that each statement that was shared by Mr. Kovalchuk could have been also discussed not only for one day, maybe for several days, but we don't want to get stuck as the evergreen in the Suez Canal. No questions from the audience.
We have a question from Thailand. In Thailand, they have a program that is developed by marine authorities together with the Ministry of Health, and they are based on international standards, IMO. This is a basic course, first aid course, which is 15 hours. The next one is 30 hours. And then for officers, it is a 100-hour course for first aid treatment, including in some emergency situations. Thank you very much. Our next speaker is Yuri Grabsky from the Federal Medical Biological Department of Russia, candidate of medical sciences, Deputy Business Development Director, Federal State Unitary Enterprise Scientific Research Institute of Industrial and Marine Medicine. The report is called Medical Supports Development for Ships Navigation on Northeast Passage. Dear Yuri, you have the floor. Hello, dear colleagues. I'm glad to see you, my colleagues and myself that are present here together with me. This year is the third time we see each other, which is very nice because the problems we are raising during our meetings are very relevant, and without close collaboration, it is impossible to solve them, to address them. That is why my today's report will be devoted to that detailed in his report all the complex support of Maritime, all these documents, medicine. Besides, it is planned to create these centers of health safety of seafarers at medical organizations within the federal state unitary enterprise which I belong to. There are some grounds for this, and we have begun work on this matter already. We have the necessary experience but this will require some time. There is also a need to create a national research and practical center of maritime medicine in Russia that would unite and coordinate scientific research and their implementation in practice. And there is a need to create a federal research and educational center of Arctic medicine. We met with my colleagues several times at different conferences. There are some achievements already done in this area. My colleagues from Moscow and St. Petersburg are putting a lot of efforts to put those ideas into practice. What has been done so far, this year in particular? We can say that this is a serious breakthrough. Although the major stages will be implemented in the future, however, I see that we are moving in the right direction. We will soon publish the second edition of the concept of the development of maritime medical care. The first edition was prepared last year. It was reviewed, and this year we will have a second edition. The guidelines for cooperation in terms of medical care in the Arctic zone, first edition. There will be the second edition of the reference book on on ship and submarine medicine. In the second edition, there will be terms and definitions so that all the stakeholders and people involved into this sphere of activity talk the same language, speak the same language. The problem committee number 3 is created that will deal with actual problems of ship and submarine medicine, medical and biological medical assistance. We expect that the orders to create this committee will be published soon. Then we will develop the working plan of this committee. And our colleagues that are engaged into this problem for quite a long time have an opportunity to address the required issues. And there is a draft order of the Ministry of Health of the Russian Federation on the order of the medical inspection or examination, and the draft order on the requirements for the medical kit. All those documents are not approved. This takes time. This is not that easy. There are different opinions, particularly regarding the introduction of some changes into the legislative base. But we're quite optimistic and hope the future will be favorable. Yesterday and today at our conference, I heard a lot of interesting reports devoted to modern technologies and how they will be implemented. But you know, sometimes we need to go back to the past. This time, we're celebrating 85th anniversary of a very important event that happened in 1936. This is the transition of 2 military ships along from Kaliningrad to Vladivostok. A person who was responsible for the medical supervision, Vasily Shestov, is an outstanding military doctor, a legend of military medicine. He published very interesting, serious, and detailed reports regarding the navigation, and he personally participated in passing through that route in quite adverse weather conditions and tried to save health and life of seafarers. These are the large ships, Stalin and Voykov, that were passing through this route. This was a relatively not a very large ship, but still quite impressive for that period of time. And after that, Vasily was awarded an Order of the Red Banner of Labor. This is the composition of the emergency kit. You see not too many items, but that was sufficient enough for the expedition to be successful. This is another interesting example, a list of emergency food for 14 people for 15 months. This is a legendary trip. Georgy Sidov in the Arctic zone. This is the emergency food kit. People spent 5 months in ice, sea conditions, fully autonomous. We know that the technologies are advancing, the medical drugs are different, the emergency toolkits are quite different. And we cannot predict 100% that the equipment will work well. Even the spacemen say that quite often things go unexpectedly. If equipment is functioning properly, the weather may disrupt the overall operation. But if the equipment and weather are good, then there is a human factor that is quite difficult to predict. That is why any serious tasks to solve such issues also requires a plan B, even for the medical stuff, in case something goes wrong, and all our regulations and plans and collaboration schemes will be irrelevant. So let's go to plan A. You have 3 more minutes left. We consider there are some requirements to change the legislative base of the Russian Federation regarding the maritime medicine. Talking about the administration of drugs according to health conditions, then there is a need to make some changes to the federal law, because this law doesn't create a regulatory base for those tasks. There is also a need to prepare some documents setting the requirements to the presence of medical rooms on board a ship, to the presence of drugs, including narcotic drugs, to the requirements to the presence of medical people. There is a need to develop a procedure for medical consultations on ship using telemedical equipment or telemetry. All this combined will allow to reach a new level of maritime medicine to solve complex issues of this sphere in the Russian Federation. Dear colleagues, thank you for your attention. If you have any questions, I'll be glad to answer them. Once again, I'm very glad to see all the participants of this conference. Thank you. Thanks for the organizing committee for inviting me to participate in this conference. We are ready. We are always ready to see you, either online or offline, and ready to move forward for the benefit of our common duty. Yuri, thank you very much. Thank you for your interesting report, for the work you are doing in this direction. Do we have any questions? There are no questions. Thank you very much. I hope to see you in the Arctic Forum in St. Petersburg in a few days.
У нас наш
Our last but not least reporter is from Aberdeen, Scotland. Is Graham Furness, is the medical advisor for the OG UK, and his report is revision of the OG UK medical. Can you hear us?
I'll start sharing my screen and carry on with my presentation.
Yes, please.
So here we are. Okay. I can't see anybody. Can someone tell me, can you see the slides?
Not yet.
Can you see them now? I
Yeah.
am sharing the screen.
Yes, now. It's okay.
Very good. Okay. So I know that this is the last presentation of the day and the last presentation of the conference. I know that you've already heard about pre-deployment screening earlier on in the conference. I know that you've heard about coronavirus on offshore installations and ships. I will talk a little bit about both of these things and tell you about revision of the oil and gas guidelines. So the UK itself is an oil-producing country, has been since 1964, so that's almost 60 years now. It is still a good place to do business because of its relatively stable fiscal financial climate, so that's the good thing. But the UK is not the biggest oil and gas producer in the world. It's about the 19th biggest oil producer. And the UK is not the biggest country in the world either. It's actually quite a small country, but we have oil and gas workers living all over the UK, and they travel up to Aberdeen and then they go offshore to work. Now, because they're living all over the UK, what we have is we have a system of medical examination before they go offshore, and an offshore worker can get his oil and gas medical done by a doctor almost anywhere in the UK because we have quite a large number of examining doctors. And I'll show you just some facts and figures. There you are. We have about 350 examining doctors in the UK, but actually we have a lot more examining doctors all around the world. In total, we have about 1,000 doctors now in 74 countries all around the world. And actually, we do have examining doctors in Russia. We have 4 doctors in Russia. 3 of them are in Moscow, and 1 of them is in Sakhalin. And you can see that actually, overall now, most of the examining doctors for Oil and Gas UK are actually not in the UK, which is interesting. And if we look at the number of medicals that are done, you can see that that has increased greatly since 2008, which is when the current edition of the oil and gas guidelines date from. The current edition of the oil and gas guidelines, the medical guidelines, were written in 2008. And at that time, we were doing about 40,000 medicals a year. You can see that that increased to almost 150,000 medicals in 2019. It reduced a little bit because of COVID, but we're still doing a lot of oil and gas medicals. You can see that the failure rate has been remarkably constant over time, which is a good thing. It means that doctors are consistently interpreting the guidance, but we do need to revise the guidance because medical practice has changed over the past decade or more. And in 2019, we began a consultation exercise on revising the oil and gas guidelines. And I'll tell you something about some of the answers we got to that. But then, of course, what happened was that COVID started in 2020, and that did interfere with the revision process of the guidelines. It forced us to make some changes really quite quickly because of COVID. And the changes that we made are the ones that I've highlighted here. In a conventional oil and gas medical, everything is done in person. The examinee attends the examining doctor. There are tests that are done. There's a physical examination. And because of restrictions to medical activity due to COVID in the UK, we were encouraged not to see patients unless we absolutely had to. So we introduced an amended oil and gas medical, which was able to be done by video conference, just like we are doing now. And what it did was it tried to reduce the number of tests that were required. It reduced the amount of physical examination, didn't eliminate it altogether. And what it did was it tried to improve on the available medical history by making sure that examining doctors were provided with the previous oil and gas medical notes, provided with some information from employers, and perhaps some confirmation of medical history from the examinee's GP. So we introduced that really quite quickly, under some pressure, but I think that in some respects there are some lessons to be learned from the introduction of this. And perhaps the first one to look at is the question of the questionnaire, the information that the examinee provides at the medical. And one of the questions we asked as part of the consultation was, do you always get an accurate medical history? And over half of responses to our consultation had a problem or had an instance where an inaccurate medical history was provided. And this is an example. This is an email that I received from an examining doctor. They had done an oil and gas medical on a 45-year-old man. That person said on his questionnaire, and when questioned directly, that examinee said that he had no significant medical history, and he said he was not taking any regular medications. He was normal on examination, so the examining doctor gave him a 2-year normal oil and gas certificate. A few weeks later, the examinee got back in contact with the examining doctor and said, I wasn't truthful. I'm actually taking bisoprolol and rivaroxaban, an anticoagulant, for atrial flutter. And quite correctly, the examining doctor was concerned about that for someone going offshore and asked me what to do about it. So I dealt with the inquiry, but there's an example of inaccurate medical history. So what should we do about that? Should we confirm the examinee's medical history in general? Well, this is a slightly deceptive slide because it begins at 46% there, but the answers that we got were somewhat split. It's almost half and half of people felt that maybe we should improve on the medical history. So a little bit controversial, but with the amended oil and gas medical for coronavirus, we have introduced a stronger medical history. And actually, I think it has worked very well. I think the option of getting, or the requirement to get some questions from the employer answered, those are questions such as, does the employer know if the person has been off sick? Does the employer know if the person has been medevaced? Does the employer know or have any concerns medically about the employee? These are quite useful questions to get answers to. Having the previous oil and gas medical notes is also very useful because often things are documented there that the examinee may not tell you about this time. So this in practice has proven to be a very good and useful thing, and I certainly think it should stay. The topics that people were particularly interested in seeing revision to in the guidance were cardiovascular problems, obesity, medications, diabetes, and psychiatric problems. And we'll just look at a couple of those just quickly. The oil and gas medical doesn't actually require measurement of blood pressure. That's an interesting thing, is that the normal oil and gas medical doesn't actually require measurement of blood pressure, but everybody does it anyway. And we asked the question in the consultation, this is a clinical question, how often should an apparently well adult have their blood pressure measured? And these are the responses that we got from doctors in the UK. And it ranged from, some doctors thought it should be every 6 months, some doctors thought it should be age dependent or maybe every 5 and 6 years. There is actually an answer to this question, because in the UK we have a set of medical guidelines, the NICE guidelines, which tell us to measure blood pressure every 5 years in apparently well adults. So 5 years is the correct answer, if we want to call it that. But you can see the variation there. Just for interest, here are the answers from the doctors outside the UK. I don't expect those doctors to know what the NICE guidelines say, but you can see that there was an interesting range of answers going from once a month up to rarely, which is interesting in itself. But here's an audit that I did of 56 medicals, oil and gas medicals done over a period of time. And what I found was that just under half of those medicals had a blood pressure above what the NICE guidelines recommend for further investigation. And the interesting thing is that virtually none of these, I think 1 or 2 of these, had actually had some follow-up of those blood pressure readings, but most of them had not. And I do ask myself the question, what is the point in measuring something at a medical if you're not going to do anything about it? And therefore, I think that we need to be more prescriptive in the oil and gas guidelines in the future. We did ask that question, should the guidelines provide greater prescription about what is required? And most people said, yes, please, more prescription rather than less. And I do think that that is going to be a feature of the future oil and gas guidelines. I have already started revising the blood pressure section to be more detailed and prescriptive about that. There is one other aspect of tests that we can look at, which is a little bit more controversial. There you are. You can see that the normal oil and gas medical says that we should do urinalysis on all examinees. We changed that in the remote medical, the video medical for COVID, and we said, don't do a urinalysis. Now that, in the consultation exercise that we did, was much more controversial. We asked the question, should urinalysis be omitted from the medical? And most respondents said, no, it should be retained. But what is interesting about that is that there is no medical organisation in the UK which recommends routine urinalysis on every single person that we see at a medical. And the question there is, what are we testing for? And is actually urinalysis the best way to test for it? Because perhaps something else might be different. So this is more controversial. We shall see what happens with that one in future. Thinking about weight for a moment or two, here is another audit that I did of oil and gas medicals. And it's a small number of cases, but you can see that most people, where we have a record of 2 measurements of their weight, 77% of people put on weight in between their oil and gas medicals. So this is a continuing problem. And we asked the question in the consultation exercise, can we set a cutoff, a pass-fail cutoff for the question of obesity of people going offshore? And most people thought that we could do, although actually people representing contractors offshore, the vendor population, were less keen on that. But most people thought we could set a cutoff. But when you look at the detail of the answers, the people who thought the cutoff could be body mass index, it ranged from a cutoff of a body mass index of 33 to a body mass index of 50, which is obviously quite a wide range. There were 1 or 2 people actually who mentioned a functional test or a physical capability assessment, and we'll bear that in mind in a second. There were some people who mentioned weight as a criteria, But again, it ranged from 120 kilos up to 150 kilos, which again is quite a range and not a consensus. And then there were various other suggestions for fitting through helicopter windows, and some people who mentioned a fitness test. It might be better dealt with by a fitness test. And one of the interesting things about the revised oil and gas medical is we did introduce a functional test, a practical functional test. We did it for respiratory disease because the normal oil and gas guidelines for chronic obstructive respiratory disease mention spirometry values, and for COVID reasons, we're not doing spirometry. So the normal guidance does mention a practical functional test where spirometry isn't meeting the standard, but it doesn't say what that test should be. So for the revised oil and gas guideline, we actually said what the practical functional test should be. And it's very simple. It's just a timed, self-paced, continuous brisk walk of 1 mile or 1.61 kilometers distance. And it says the time that they should be able to do that in, which is they should be able to do it in less than 19 minutes. That's actually very generous. Try it for yourself. Go for a brisk walk and see how long it takes you to cover 1.61 kilometers and see if you can do it in less than 19 minutes. I hope you all can. So we have introduced a practical functional test, and I do think that that simple practical functional test will go into the revised guidelines, not just for respiratory problems, but for obesity as well. And then the final comment I'm going to make is just one other big lesson from COVID is that it has surprised me just how readily and how easily the industry has adopted the idea of a pre-mobilization check. Up until 2020, the only thing you needed to go offshore was your oil and gas medical certificate. From 2020 up until now, because of COVID, you cannot go offshore unless you have a check, a COVID test, and perhaps a temperature test before you actually go offshore. And I did suggest, Oil and Gas UK had a health and safety conference earlier on this year, and I did suggest at that we might do something more. We might keep a pre-mobilization check and do something more with it. You know, maybe we might check blood pressure before a person went offshore. Maybe we might check weight before a person went offshore. Maybe we might check what medications a person was taking before they went offshore, rather than have them come back from offshore when we find out what they're taking offshore. And then the question of mental health has been one of great interest. And I did suggest that maybe we might just check, are people feeling well enough mentally to go offshore? But it was interesting that the response I got to that suggestion was not enthusiastic. So I don't know if I should have been surprised at that or not, but there wasn't enthusiasm for that pre-mobilization check. So really, in brief summary then, my conclusions from my experience of the revisions that we've made with the oil and gas guideline for COVID and the consultation exercise is that I think that one of the most important things we need to do is to think about how we can improve on the accuracy of the medical history. I think that a big lesson about tests is that if we're going to do a test, we should really do it properly and act properly on the results. And I think that for some things, we can actually introduce a nice, simple, pragmatic, functional test without too much complication. I think that's the best sort of test to introduce. And I do think that the industry appetite for a non-COVID last-minute check is doubtful. So I think that it will still be the oil and gas medical that will be the way that we will do things in future. So that's really just a brief summary of my experience over the past year and a half or so. So I'm happy to take questions from anybody, if there are any.
Если у нас вопросы из зала. There is no questions. Thank you for the brilliant presentation.
You're welcome.
Thank you.
You're welcome.
Я должна сказать, что Грейхэм, как атлант, он на своих плечах держит
Graham is like the Atlantis. He, on his shoulders, is pulling the whole horse for the training of the OGUK. I was one of the persons who was certified as the OGUK trainer, and I had a pleasure of meeting him. So he was training us for the whole day without any pauses and breaks in one building.
Just a moment.
Я правильно понимаю, вы одна из 4 врачей из...
Ilona, are you the one of the 4 people in Russia who has the certification? Yes, I'm one of the 3 in Moscow.
And have you been doing remote medicals?
Yes, I do. From the beginning, it was really strange for the patients, but it's quite okay. It's quite okay because, you know, if the person has to travel from Murmansk to Moscow as a clinical, you know, physician, I personally prefer to do it online and not to put him in danger, you know, to the exposure of virus.
Yeah, no, very good. So you've been able to make it work and it's worked well for you. So that's a good thing.
Yeah. Thank you. Я одна из
You're welcome.
тех, которая еще делала вот на расстоянии эти сертификаты АГУК в начале.
All right, so she's also explaining it again in Russian. So I was one of the first person who did the OGUK remote tests, but it was weird initially. But as a clinicist, I would say that it's easier not to travel from Murmansk to Moscow than to put a person in danger of contracting a virus on their way. We had different other efforts enable maybe to extend the OGUK certificates maybe more than 2 years for us not to do additional tests, but hopefully very soon we are about to see the end of the pandemic time. Thank you so much, Graham. Our conference is not about to end. We will have now 15-minute break for the technicians to change the configuration in the hall. But please, audience offline, be back.